So when I reflect on our sort of transformation journey, I think about what tools or what things along the way really helped us get over some of the hurdles of either inertia of just not wanting to do it or just not knowing how to. And at least for us, I think the PCMH framework, when it was first outlined, gave us a nice way to create sort of that gap analysis. But I think what really helped was when we had the AAFP and TransferMed come do a full day retreat with us. That really helped us to the next level. One is they gave us tools that we could use. Mm-hmm. Secondly, they gave us ideas on how to move forward. So I think that really facilitated our continued transformation.
Well, I think they also, they kept asking why. Why are you going to do this? You know, because it's a big lift. And so when you look at the why, and it really was making sure that everyone in the organization was bought into the idea that we were going to be market leaders in doing this, because no one else in the market at the time had been even going down this road. So I think we had maybe it's because of our residency program and our educational mission, but we pretty much got buy-in that we were going to be market leaders. And that in and of itself, I think, created challenges because we didn't really have a recipe that anybody had followed. So TransferMed really helped us with some real good guiding principles. And the one other takeaway at the time is that we realized that we could, even if we convinced all the doctors that this was the right thing to do, if we did not convince our employees that this was the right thing to do, we would probably fail. So we ended up, really the year before we did a lot of the clinical pop health work, we brought in a whole training program for our employees on, and we called it The Journey, and here's why we're going to do it, and really started educating our employees, all of them, as to what was happening in the market, why we thought this was the right thing to do, why we thought this would improve health care for the patients that they serve every day, and why we wanted to go down this, a journey. And we still, actually 10 years later, we're still talking about the journey every year with our employees.
And I think a big part of that, at least for me, was the physician leadership that it took. Mm-hmm. Now, I use the word leadership and not necessarily leaders because you as a non-physician and other of our senior administrative staff truly led the process. But I think a key point for us was getting buy-in from the physician owners, mm-hmm. who had to see the advantage or the potential advantage to continued practice transformation and be really the, what's the word I want to use? Provide that leadership and encouragement that when things weren't going well to say, no, keep the goal in mind. This is where we need to go as a practice. This is the future. And really provide the guidance that was needed for the rest of the organization.
Well, and we ended up having to do that assessment every year because I think to keep people motivated and to still, keep asking why are we doing this? And the answer was always to improve patient care and to engage our patients, but you still really have to reflect every year as to what have you accomplished, what are we spending money on to try to build in this whole process, and then how are we making sure that our patients are satisfied and our employees are satisfied and the work that we're doing with the providers, the tools we're using. So we did an annual assessment every year just to make sure that the resources that we were putting into this were still valued and necessary. I'm trying to think, it was the first time in the history, I think, that we even spent some money on training for our middle level supervisors. So we really thought, that employee buy-in and understanding the why really helped, I think, the whole process come together a lot better. And I think the patients then could see the outcome because they're with staff actually more than they're with the doctors. Mm-hmm. And I think having even sidebar conversations with our patients about why, we're now proactively calling them instead of waiting for them to call us, or why are we calling them about a gap in care and you got to go get your mammogram done. And I think the patients started understanding that, and when they got the calls then from the staff, it wasn't this negative. It was more of a positive because everybody knew what was going on and why we were doing this.
I think that's really true. The other piece that I think was important was, as you reflected on, was the value of the team, and making sure that the team, everyone from the phone center to the front office staff, to the nursing staff, to the physicians, your advanced practice providers, knew what this journey was about and why we were doing it, and making them realize that at the end of the day, the person at the front staff was just as important to the care of our patients as the provider was. And that sense of ownership and accountability for that, I think, was a key issue that we tried to inculcate throughout the organization.
We did, because I think it was probably back in 2015, we went through a whole year with all of our employees. We created an employee-based committee. Actually, none of the doctors or myself, none of the senior management was on that committee, and they came up with the value statements for the organization, and then we had the whole company vote on it. So it was, again, a bottom-up built, this is the values that we're going to live by, this is how we're going to serve our patients the best way we can. And they were also involved in some of the decision making about some of the tools that we ended up buying. Not the EMR per se, but maybe how the workflows. So all the workflow changes came from employees, and we really encouraged that. We had another tactic that worked pretty well, because we have 13 locations within our organization, is that we had some care center competition going on certain things about, how do you solve for BMI, because you needed to get the weight and the height on every patient every time, and nobody wanted to do it. So we ended up doing a competition, and the nurses, I'm going to win this week. We're going to get everybody's BMI. And so we got a metric track that way. So I think those are really some tactical things that end up, giving people, we get the outcome we desire, but we're having a little fun along the way, if you will.
But I think a point you make there, it's so key to the transformation, is you have to measure things.
Yeah, that's true.
If you really want to make a change, you need to measure something and then give feedback on that measurement, and then look at, is there a process intervention you can do to improve that? I mean,
that's a very good point, because back in 2010, before this transformation started, we didn't measure a lot of things. We didn't have metrics around patient satisfaction. We didn't have metrics around we did try to do some budgeting, but we weren't measuring process or outcome. And this whole journey really is focused on measuring things. Because there's so much change, you have to make sure that change is meaningful, and the only way you can do that is to track it over time and then modify. And I think, now looking back and think about the changes that we've gone through. And I think the one thing that we also did a lot of education around is that change was good. Change was not a negative, and that the employees that we hired and that we kept and encouraged them to come up with new ideas and new workflows that might improve. In fact, we just encouraged change management if you could, and we did a lot of leadership training around change management.
I was just sitting here thinking that this is all well and good. We want to take better care of patients. We want to have an energized and overall happy workforce. But at the end of the day, to use an old saying, no margin, no mission. And especially as a private practice group, we have to make sure that this transformation has been done and kept as financially viable and hopefully healthy. And fortunately, and you can address this better than I because you are on the contracting level, that by meeting the higher quality measures, by collecting this data and doing a better job of managing our population has led to enhanced reimbursement.
Yeah, it has. It has. We spend more of it in the population world, but it has led to higher reimbursement, and I think there's still challenges in that, and I think we still have to work with these insurance companies and the federal government on programs that lead to the right incentives all along the way, from not only the patients and the providers, but even employers. Right now, we're still not aligned on, I think, even benefits packages and how they're working. And until we as an organization and really primary care really help in eliminating financial barriers for the patients to come and see us as providers, I think we're going to have a huge challenge in this country. So I'm hoping that these high deductible health plans, which are frankly a pretty big challenge for a lot of people right now, are going to be fixed with some of benefit design changes, that at least patients will be incentivized to come see their doctor or go to an urgent care center versus not going and seeking care at all, which is what we're seeing a little bit of now.
And I think another piece of this pie that we've tried to enhance is the idea of comprehensiveness, to make sure that we're providing as comprehensive care as we can within our practice, depending on our expertise as individual providers, and also taking advantage of the expertise within our practice. One concrete example, I did obstetrics for years but never learned how to do colposcopy. However, two of my partners do that procedure. So instead of referring to one of the local gynecologists, I just refer sort of in the practice to one of my other colleagues. As a rule, the patients enjoy that. They come to this practice to be taken care of. And if we can provide that same expertise here, usually we do it at lower cost, and at the same time we're enhancing the relationship and contributing financially to the health of the organization. So one of my challenges to practice is to make sure you're tapping into all the expertise that exists within your organization to take care of your patients. And I think at the end you'll have a happier patient, and again, it'll contribute to the bottom line.
Well, and another tactic related to that is actually in quite a few of our care centers, we sublease space to specialists so that they'll come in a couple days a week and basically meet the patient at our office versus having to travel to a specialist office. And especially for subspecialties that really don't have, there's not enough volume to have a full-time office. I think having the option of hoteling space, if you will, if you have that ability, is another way to keep that comprehensiveness going. Yeah.
Hoteling, is that's been trademarked? Like it?
I guess hoteling. I don't know.
Hoteling.
Hoteling.
I don't know. But it has been. I mean, we have a cardiologist that comes here and a couple of days a week, and I found, number one, he's there to talk to. I think we're starting to get some early data that his utilization of higher end studies and tests is less than we've seen with some other cardiologists in the community.
Yeah.
And I hate to say it, but it's what family docs are about, is relationships. Not just relationships with our patients and our staff, but relationships with cost-effective and like-minded subspecialists in the community, which I think, and again, I'm not sure I have data for this, but I think if you have those relationships down the road, it's going to save money for the patients.